ओके, कैन यू कंफर्म कि अब वॉइस आ रहा है? हाँ, चेक कर लीजिए। सो स्टूडेंट्स, कैन यू कंफर्म वेदर आई एम ऑडिबल टू ऑल ऑफ यू? इंदिरा, जैसे आप कंफर्म कर दोगे तो मैं एम आई ऑडिबल गाइस? ठीक है, ओके। So guys, I just want a thumbs up from you if I'm audible or not. Okay, so now I'm audible, right? Good. So we'll start with the session. Okay, so in the previous session we have learned about the axis determination. So today we will be talking about the P waves. अब जो time मेरे पास है to address the ECG sessions, I may not be able to discuss each and every problem that we are taking up during each session. बट हर प्रॉब्लम का जो भी हर सेशन में जो भी हम प्रॉब्लम्स डिस्कस करते हैं ईसीजी का, या जो मैं होमवर्क आपको देता हूँ, उसका रिटन सॉल्यूशन अगले क्लास से पहले टेलीग्राम पे आपको मिल जाएगा, राइट? सो वट एवर ECG problems that we had in the previous module, the written solution I will make it available by today night in the Telegram group, so you can download it from there and you can analyze whether your answers were right or wrong, right? So today we will start with the P waves. Now we have understood rate determination pata hai, axis determination pata hai. Now we are getting into more serious business, right? We are trying to identify abnormal waveform segments and the intervals. So we will start with the P wave. Okay, अब P wave कैसे प्रोड्यूस होता है? We know that the P wave is produced because of the depolarization of the atria, and the depolarization wave is started by the SA node, which spreads through the right atrium and causes the right atrial depolarization. And from the right atrium there is a specialized bundle that takes this wave of depolarization to left atrium, which we have already called it as Bachmann's bundle. It is Bachmann's bundle. So now I have a question: which chamber gets depolarized first? Is it right atrium or is it लेफ्ट एट्रियम? सो अगर आप कहना चाहते हो कि सर दोनों साइमल्टेनियसली डिपोलराइज होते हैं, तो इट इज अगेंस्ट द लॉज ऑफ फिजिक्स, राइट? व्हाई इज इट अगेंस्ट द लॉज ऑफ फिजिक्स? बिकॉज द लॉज ऑफ फिजिक्स सेज कि for something to travel from one point to another, it will take time, right? So it is much more easier for me to send an electrical impulse from SA node to right atrium than to left atrium, because left atrium is positioned far away in comparison to right atrium. So which chamber generally tends to get depolarized first? It is the right atrium. The left atrium will get depolarized little later. Okay, so in the ECG, why I get only one P wave? I'm expected to get two P waves, right? One because of right atrial depolarization, other because of left atrial depolarization. But why do I get only one? The reason for that is the time gap between the right atrial depolarization and left atrial depolarization is very minimal, so I will end up seeing it as a single wave. So far what we know, P wave is due to, it is due to atrial depolarization. but इस P wave के अंदर अंदर inside this P wave there are two waves, right? Atrial depolarization leads to P wave, but within the single P wave there are two P waves, one because of right atrial depolarization. So let me say this is a wave of right atrial depolarization, jo this happens first, and then this will be followed pretty soon by the left atrial depolarization. So this blue color is the wave of left atrial depolarization. But in a standard ECG, the time gap is so minimal that I may not be able to see it as two separate waves, but it may appear to me as a single P wave. Clear? Okay. Now this P wave, if I want to see it, what would be the best lead to see the P wave? Which lead can be considered as best lead to see the P wave? The best lead to see the P wave is either lead 2 or lead V1. These two leads are considered as best leads for visualization of the P waves. Okay, I'll tell you why and how P waves looks in these leads. Now what is the lead 2 position? Lead 2 is positioned here, right? Lead 2 is for the inferior wall of the heart, right? 2, 3, AVF are the inferior leads. So lead 2 is positioned here, and that means the camera for the lead 2 is here and it is looking at the atria, right? Now when the depolarization spreads from atria, from SA node through atria, right atrial wave is spreading downwards and the wave for left atrium is moving slightly leftward. But from the perspective of lead 2, what is it looking like? This is also coming towards the camera, and this is also coming towards the camera. So both in lead 2, both the right atrial wave and left atrial wave will produce same positive deflection, right? So in lead 2, I will get one wave due to right atrial depolarization and another wave due to left atrial depolarization, and both of them are happening in close succession. So for me, the end result is it looks like one single P wave. It looks like one single P wave. So this is the perspective of lead 2. So when seen from the lead 2, the wave of depolarization is coming towards the camera, whether it is for the right atrium or whether it is for the left atrium, both of them are coming towards the lead 2. So it looks like one positive right atrial wave, one positive left atrial wave. The gap between two is minimal, so it gives me a summative picture as one single P wave. Now when I look at the P wave from the perspective of V1, right, V1 is for the lead for septum. So V1 is looking at the septum, interventricular septum. It is looking at this. So from the perspective of V1, the right atrial wave of depolarization is coming towards it, but left atrial wave of depolarization is going away from it. So in V1, what will I notice? The right atrial wave will be a positive wave and the left atrial wave will be a negative wave. The right atrial wave is positive, but the left atrial wave will be negative. Why? Because when I see from this side, the right atrial wave is coming towards it, left atrial wave is going away from it, right? यहाँ से देखूंगा तो I can see that this is going away to cause the depolarization of left atrium. This is coming towards the camera. So I can get a monophasic single P wave in lead 2, but biphasic P wave in lead V1. These two are considered as the good leads for recognition of P waves. Okay, so now we have the clarity, right? This is the point of view of the lead V1 and this is the point of view of the lead 2. So that tells me why I get a positive P wave in lead 2 and a biphasic P wave in lead V1. Okay, that is clear. Now we will try to understand how a normal P wave will look like. The normal P wave in lead 2 will have a height and a width, right? So width measures its duration, height measures its amplitude. So what is the amplitude of normal P wave and what is the duration? So the duration of normal P wave is less than 100 milliseconds. That means for atria to get depolarized completely, it takes less than 100 milliseconds. And to be able to execute a good depolarization of the atria, I will require less than 0.25 millivolts of voltage. 0.25 millivolts of voltage. That's the morphology or dimension of the normal P wave. So now you should tell me in terms of small boxes, right? Height में कितना small boxes होंगे and height में how many small boxes and width how many small boxes to call it as a normal P wave. When can I call it as a normal P wave? Duration 100 milliseconds, right? One small square is 40 milliseconds. So how many small squares the P wave can maximum occupy? 2.5 small squares, right? Height wise, one small square is 0.1 millivolt. So how many small squares height wise the P wave can maximally occupy? 2.5 small square. So in simple words, width wise 2.5 small squares, height wise 2.5 small square. So a normal P wave is supposed to occupy less than 2.5 small squares width wise, and in terms of height also it is supposed to occupy less than 2.5 small squares, less than 2.5 small squares. So simple way is 2.5 into 2.5, right? When it is more than that, it is an abnormal P wave. Now abnormal P waves, what do they indicate for me? The P waves are likely to become abnormal when the dimensions of the atria change. When the dimensions of the atria are going to change? When I have either right atrial hypertrophy or enlargement, or I have left atrial hypertrophy or enlargement. So if right atrium is enlarged, to cause its depolarization, right, I will require more voltage. So the voltage required will increase. So the amplitude of right atrial depolarization wave will also increase, right? Now if I have caused enlargement of the left atrium, so this electrical impulse to reach and depolarize the left atrium will take more time. So this left atrial wave of depolarization will appear late and it will be taking more time to complete the depolarization, right? That's the basic understanding. So now we will look at the abnormalities of P wave. So the first abnormality that we're talking about is tall P waves, where the amplitude is increased. Tall P waves. So when do I call it as tall? Normal, I have defined normal is less than 2.5 small squares or less than 0.25 millivolts. So when the P wave amplitude is more than 2.5 small squares, which is equal to more than 0.25 millivolts in terms of voltage, we will call it as tall P waves. And these tall P waves are also called as, they are also known as P pulmonale. So why am I calling it as P pulmonale? The reason for calling them as P pulmonale is the most common cause for tall P waves is right atrial enlargement. Why right atrium usually gets enlarged? Any cardiac chamber gets enlarged when it is doing more than usual work. Basically, it is developing hypertrophy, right? How do we develop hypertrophy of the muscles? By going to gym and lifting weights. So if right atrium is doing more work, just like how we do by going to the gym, then it will develop hypertrophy. When right atrium will do more work, when it has to forcefully push the blood into the ventricle, which is not ready to receive. When ventricle is not ready to receive, when it is developing hypertrophy. So when right ventricle has hypertrophy, right atrium needs to put more blood into the right ventricle. And when right ventricle develops hypertrophy, it is putting a lot of efforts to eject the blood into pulmonary artery. When it needs to put a lot of effort, when I have pulmonary hypertension. So if pulmonary artery pressure is already high, to push blood into this high pressure vessel, right ventricle will be doing a lot of effort. So it will develop hypertrophy. Now to push blood into this hypertrophic right ventricle, the right atrium needs to put a lot of effort, so it will develop hypertrophy, right? So it all started where? Because of the pulmonary hypertension. Pulmonary hypertension led to right ventricular hypertrophy, that led to right atrial enlargement, right? So this is the most common cause. Pulmonary hypertension is the most common cause for tall P waves. That's why we call it as P pulmonale. P pulmonale. So if I see P pulmonale, right, what is it suggestive of? It is suggestive of right atrial enlargement. Mumaina Beg, yes, I'll come to that. So right atrial enlargement. So if I see any ECG where the P wave is more than normal in terms of height, it is suggestive of right atrial enlargement. Is there some hypertrophy in heart as well for people doing gym? Yes. So athletes, not just the gym, any form of athletes, including marathon runners, high jumpers, long jumpers, their skeletal muscles, body muscles are overworking. So to meet their demand, the muscles demand of blood supply, heart also overworks. So that often leads to some degree of left ventricular hypertrophy. Not the right atrial hypertrophy, but the left ventricle, because when my skeletal muscles are overworking, which chamber needs to do the most work? It is my left ventricle, which is pumping the blood to my tissues through aorta. So left ventricular hypertrophy is very common in athletes. Other cardiac changes that are common in athletes is their heart rate is usually lower than general population, right? So they have bradycardia in comparison to general population. That is the second change we need to know. Okay. Now I will give you an ECG and let me see if you can recognize whether that patient has got P pulmonale or not. So how do I recognize whether patient has got P pulmonale or not? All I have to do is I have to measure the height of the P wave, right? What is the normal height of the P wave? Normal height of the P wave is less than 2.5 small square. So now go through this ECG. So when you see this ECG, what is it suggestive of? Do I have the P pulmonale here? What is the amplitude of this P wave? How many small squares it is taking? Normal we have defined, right? Width wise less than 2.5 small squares, height wise also less than 2.5 small squares. So now how much it is taking here? Width wise it is barely 2 small squares, right? So duration of the P wave is not increased. So time taken for atrial depolarization is not increased, but the amplitude or voltage required to cause atrial depolarization here is increased, because 1, 2, 3, 4, little more than 4, right? At least 4 small square is what I see here. 4, 4.5 you can say. So what is the P wave amplitude in that case? 4 or 5 if we count. If I count 4, it is 0.4 millivolts. If I count 5, it is 0.5 millivolts. Is it more than 0.25 millivolts? Yes, of course. So that means whatever I'm seeing here, this is a tall P wave, right? This patient has got P pulmonale. That means this patient has got the right atrial enlargement. Now he may be having pulmonary hypertension or other causes for right atrial enlargement. So now here I can make a conclusive diagnosis that this patient had the right atrial enlargement. Now what can happen if I have left atrial enlargement? If I have left atrial enlargement. Now if I have left atrial enlargement, what will happen? The right atrial wave will appear as usual, because right atrium is not enlarged, its amplitude will be normal, right? But the wave of depolarization that is reaching the left atrium, its amplitude will slightly increase. Normally it is slightly lower than the left atrium. It may increase a little bit. That's not the big deal. The main issue is if the left atrium is enlarged. Right now this is the position of my left atrium. So for this wave of depolarization through Bachmann's bundle to reach and cause the depolarization of the left atrium will take more time, right? So left atrial depolarization is not going to begin at the usual time. It is going to start little late. So now what I see, this left atrial wave of depolarization starts little late. So when it starts little late, what change I notice? Earlier I was not able to see the difference. Earlier I was not able to see the difference between the two waves. They were appearing like one wave for me in the lead 2, but now when I look at the lead 2, I can clearly see that these are split into two, one because of right atrium, the other because of the left atrial enlargement. So in that case it is clearly indicating that I have left atrial enlargement. That's why left atrial wave of depolarization is taking longer time and is appearing later. This kind of P wave, we will call it as bifid or split P wave, right? We will call it as bifid or split P wave. So the second abnormality that we're going to talk about is the bifid or split P wave. What does that suggest? It is suggestive of left atrial enlargement, and this bifid or split P wave will also be known as P mitral. I'm going to call them as P mitral. Why am I calling it as P mitral? Because the most common cause for left atrial enlargement. What is the most common cause for left atrial enlargement? Bifid P waves are suggestive of left atrial enlargement. And in what condition I can have left atrial enlargement? So P waves becoming taller than 2.5 small squares, right? 2.5 small squares is my P pulmonale, which is suggestive of right atrial enlargement. Now P waves becoming split with a clear right atrial wave and a clear left atrial wave is what we call as the P mitral, right? This is the bifid P wave that I was talking about. This is suggestive of left atrial enlargement, and the most common cause for left atrial enlargement is the left heart disease, mainly mitral valve disease. See, remember, this is my left atrium, this is left ventricle, this is right ventricle, right atrium. Okay. Now the blood from left atrium generally drains into the left ventricle. Right. Now if my mitral valve opening is narrow, so now to push the blood into this left ventricle, my left atrium needs to put lot more effort, right? What is happening here? Mitral stenosis is there, and to be able to pass the blood down through this narrow opening, I need to push more force. So now my left atrium is doing more work, pressure inside the left atrium increases, and to compensate, the left atrium will dilate. So like left atrial dilatation and hypertrophy can happen when I have mitral stenosis. Another condition it can happen is if I have left ventricular hypertrophy. Let us say I have concentric left ventricular hypertrophy. In that case, my left ventricular cavity size has become very small. And for me to be able to push the blood into this small left ventricle, the atria needs to put a lot more effort, right? Just imagine that I have to force some volume of blood into a collapsed balloon versus I have to force some volume of air into a open box, where it is going to be more difficult, where I need to put more effort. To blow into an open box, I don't have a difficulty, right? Larger the left ventricle, putting the blood into it becomes easier. But if it becomes smaller, pressure inside the ventricle is already higher side. So I need to elevate the left atrial pressure even more to be able to fill the ventricle. So even when I have left ventricular hypertrophy, I can develop left atrial enlargement. So what do we learn here? The left atrium tends to enlarge when I have some disease affecting the left side of the heart, right? And most common circumstance is if there is a problem in the mitral valve. If mitral valve is opening narrow, I have to develop dilatation of the left ventricle. And because mitral valve pathologies lead to left atrial enlargement, we have called this wave as P mitral. So P pulmonale or tall P waves when I have right atrial enlargement, right? And P mitral or bifid P waves when I have left atrial enlargement. So from the P waves, I can identify which chamber is enlarged. Is it right atrium or is it left atrium? So let me see if I have an ECG of the P mitral. So now just look at this ECG. So when you look at this ECG, what do you notice? In this ECG, the P wave is split into two, right? We can clearly see that there is a right atrial P wave and there is a left atrial P wave, and the gap between this is clearly visible as a notch. So this is what we call as the P mitral. So this patient probably has left atrial enlargement. Whatever ECG we saw early, this patient has right atrial enlargement. So left and right atrial enlargement we can recognize on the ECG. Okay. Now having done with this, what other abnormalities of P wave I can expect? P waves may be absent. When they can be absent? They can be absent in conditions like atrial fibrillation, PSVT, and the SAA blocks, right? All of these are separate entities. We will discuss them separately in individual chapters. When we talk about arrhythmias, we'll talk about atrial fibrillation, PSVT, and when we talk about the SA nodal blocks, we will talk about the absent SA waves, absent P waves in that case. So now from the P waves, we will move ahead. As the electrical impulse travels from SA node, it will now encounter the AV node. AV node will receive this impulse, does the necessary delay, right? AV nodal delay, and then pass down the impulse to His bundle. His bundle through the bundle branches, eventually through Purkinje fibers, causes the depolarization of the ventricles, and this will produce a QRS complex, right? AV nodal delay will produce the PR segment, and the wave of depolarization traveling from SA node through atria will produce P. So I will have a P, PR segment, QRS complex. This is a normal ECG. Now in this sequence, after P, I am encountering PR segment, and in terms of time frame, we are talking about PR interval. So next up, let us talk about the abnormalities of PR interval. Just for the recap, we will understand what is PR interval and what is PR segment. Most of you who are following from the beginning, you know about it already. Okay. Now I'm going to sketch or draw two lines. There are two lines, one in blue color, other in green color. If you are able to see clearly, there is a blue pair of lines and green pair of lines, right? So between these two lines, somewhere there is a PR segment and somewhere there is a PR interval. So can anybody tell me where is the Umar? Yes, in systemic hypertension also we can have P mitral. Why? Because in systemic hypertension we can develop left ventricular hypertrophy. Left ventricular hypertrophy can lead to left atrial enlargement. We can have P mitral. The reason we have called it as P mitral is because it is clearly visible on the ECG when left atrium becomes significantly enlarged. That much enlargement is usually seen in mitral valve disease. That's why we call it as P mitral. But it is possible to be seen even in patients with systemic hypertension. Okay. So the basic rule is the segments do not contain a wave and intervals always contain a wave in them. So whatever I have between green lines is the PR segment, and whatever I have between the blue lines, it is the PR interval. Interval always contain a wave. Without wave, it is only segment. So the green line stuff is PR segment, and the blue line contains PR interval. So what all is there in the PR interval? In the PR interval, there is P wave and PR segment. So what P wave indicates? P wave indicates the atrial depolarization. PR segment indicates the AV nodal delay. So PR interval encompasses the time for atrial depolarization and AV nodal delay. So if atrial depolarization increases, time for atrial depolarization increases, PR segment will become wider. If AV nodal delay increases, the PR interval will become wider. If AV nodal delay increases, PR segment becomes wider. So the net is PR interval also becomes wider. Okay, clear? So now just going back to the basics. Why PR segment and PR interval are so important for me? See, remember the PR segment is suggestive of the AV nodal delay, which is essential for the survival. Because when atria contracts, just give me a second. So when atria contracts to eject the blood into the ventricles, at that time ventricles should not be in a contracting state, right? They should be in a relaxed state to receive. So jo electrical impulse atria cynical, right? It should not reach the ventricle immediately. If it reaches, as soon as atria finishes contracting, even ventricles will start contracting. So there is no time for us to transfer the blood from atria to ventricle. So I have to, by default, allow first atria to contract so that blood gets squeezed into the ventricles, and then once the ventricles are filled, then the ventricle should start contracting. So I need a gap between atrial contraction and ventricular contraction. The responsibility of creating this gap lies on the AV node. So what AV node does is, once the impulse come to it, it will not let the impulse to pass to ventricle immediately. It does the necessary delay, 0.15 millisecond delay it does, and then it passes on to the ventricles. If it does not do the delay, then atria contracts, almost simultaneously ventricles contract. So can I transfer the blood from atria to ventricle? No. Can ventricles synthesize blood to eject from their own? No. They are dependent on atria. So if atria doesn't give, ventricles can't eject blood, right? Okay. Now basic question again, I had asked you earlier also, if wave of depolarization, if it is reaching the end of atria, why doesn't it pass down to ventricle directly? It does not pass down to ventricle directly only because the cells that are there in the atrioventricular junctions, they comprise of tight junctions. Cells everywhere contain gap junctions. So from one cell, the electricity can diffuse to the next cell, but not between the atria and ventricles. So for the window of entry of electrical impulse from atria to ventricle is only one, that is AV node. Whatever happens to atria, that impulse will pass down to ventricle only through AV node, not from any other location. What will happen if I create a breach in this tight junction? Now the impulse that is reaching the end of the atria will percolate into the ventricle immediately, bypassing the AV node. AV node does the delay, but here now there is no delay. So without the delay, impulse is reaching the ventricle. So now this PR interval helps me to identify whether the AV node is being bypassed or not, and whether the AV node is working fine or not. That's why PR interval is very, very important, right? So we will begin first by understanding what is the normal PR interval. The normal PR interval is 120 to 200 milliseconds. That means from the beginning of P wave to the end of PR segment, that is beginning of next QRS complex, this interval should take 120 to 200 milliseconds. We have already studied the duration of the P wave. It is usually less than 100 milliseconds, little more for the PR segment. So it can be somewhere 120 to 200 milliseconds, right? So in terms of small squares, how many small squares the PR segment can occupy? 120. One small square is 40 milliseconds. So 120 means 3. So 3 to 5 small squares. So in any ECG where the PR interval is taking more than 5 small square, it is prolonged. In any ECGs where PR interval is taking less than 3 small square, it is shortened, right? So I will give you an ECG now. You should tell me whether the PR interval is normal here or prolonged, right? This ECG we have already seen. In this ECG we were talking about P pulmonale. So P pulmonale we have recognized. Now we will see PR interval. It begins here, right? And the QRS segment starts here. So between these two lines, how many small squares it is taking? This one is clear, this two is clear, this is 1, 3 and little more than 3. Again, I will zoom in. Okay, I can zoom it maximum this. So this is roughly 1, 2, right? 3 and little more than 3. So 3 or little more than 3. So perfectly it is in the normal range, right? It is around 120 or maybe 140 milliseconds. Like if I count it as 3.5 small squares, it is around 140 milliseconds, which is perfectly normal. So that means this patient has P pulmonale, but no abnormalities of the PR interval. Okay. Now let me show you another ECG where you have to calculate how much is the PR interval. If the PR interval is prolonged, what does that suggest? A prolonged PR interval, what does that suggest? So just give me 1 second, I'm just picking up the ECG. So PR interval indicates time taken for the wave of electrical impulse to travel from SA node to ventricle. Within that, we have time taken for atrial depolarization, that is P wave, plus the AV nodal delay, right? Any condition where atrial depolarization takes more time or AV nodal delay is increased, the PR interval will become prolonged, right? Clear? So now look at this ECG and I want you to measure the PR interval here. So what is the PR interval here? So let us count this as one small square. This is 1, this is 2, 3, 4, 5, right? It is roughly 5 or maybe little more than 5. If it is little more than 5, I know the PR interval appears to be increased here, right? I will show you one more. Now measure the PR interval here. How much is the PR interval here? This is my P wave. This is the beginning of QRS. So this is the PR interval. So how many small squares it is taking? You should tell me quickly now. You should not waste time. Right? Now you already know the basics. Already 5 small squares are there, right? One large box is equal to 5 small square. PR segment itself is taking 5 small square. So plus P is definitely more than 5. So that means here PR interval is increased, right? So it is like 4 small squares plus 5, it is almost 9. So 9 into 40 milliseconds. So here I have PR interval of 360 milliseconds. Okay, clear? So now we know how to calculate the PR interval in any given ECG. Now we'll see in what condition I can get the abnormalities. So abnormalities wise, I can have short PR interval. So when it can become short and when it can become prolonged. When I can call it a short, when PR interval is less than 120 milliseconds. The meaning of it is less than 3 small squares. So when it can become less than 3 small squares, when I create a bypass in the conduction from SA node to the ventricles. So now normal situations, I have a layer of cells which contain the tight junction. So whatever is the wave of depolarization that causes the depolarization of the atria, cannot reach the ventricle directly, right? It will cause a depolarization of the atria, then it will reach the AV node, and AV node is the only window of opportunity for me to pass down this information. So that causes the classical normal PR segment because of the AV nodal delay. But now let us say that there is someone who is born with a breach in this tight junction cells. So now what will happen? Normal wave will reach the AV node. AV node is holding and causing the delay, but the wave that has reached the edge of the atria, there is nobody to cause delay, so this will immediately pass down to the ventricle. right? And the ventricle will start getting depolarized from the wave coming from this breach or this site. So now ventricle started getting depolarized early, right? Even before it came from the AV node. AV node is doing its job, that is AV nodal delay. So such conditions, we will call it as pre-excitation syndrome. So the causes for prolonged PR interval, right? Increased PR interval. For the sake of exam, the first and most important cause is pre-excitation syndrome. Now, what do I mean by this pre-excitation syndromes? Why are we calling them as pre-excitation syndromes? Because here ventricle is getting excited or depolarized much before it is supposed to actually get depolarized. Actually, it is supposed to get depolarized after the AV nodal delay. But here I am bypassing it and causing the ventricle to get depolarized early, right? So because it is getting depolarized early, we're calling it as pre-excitation syndrome. So for the sake of exam, there are two important pre-excitation syndromes. The first one, we call it as the favorite of examiners, that is Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. The second one is Lown-Ganong-Levine syndrome or LGL syndrome. Both of these are pre-excitation syndromes. Now, this breach that I am seeing here, I can call it as an accessory pathway. Normally, the wave of depolarization should only reach through the normal pathway, which is AV node to His bundle to bundle branches. But here it is reaching through this breach. So this I can call it as accessory pathway from which the impulse can go down to ventricle, right? So this I'm going to call it as an accessory pathway. So pre-excitation syndromes are usually due to presence of accessory pathway, like the pathway that we see in a patient with WP syndrome. That accessory pathway is called as bundle of Kent, which is seen in WPW syndrome. Okay. Now, what other conditions I can have? Short PR interval. A lot of drugs are known to cause short PR interval. So drugs and its impact on the ECG, I will do a separate session because that's an MCQ zone, like pharmacology and medicine will try to combine. So drugs is another condition, right? Apart from that, if heart rate increases, like if I have to do 200 contractions of the heart in 1 minute, right? ECG has to shrink. So usually it is the QT interval that shrinks, but eventually even the PR interval will shrink. So in conditions with tachycardia of whatever cause, I can have short PR interval, right? Our main focus should be on the pre-excitation syndrome, particularly WPW syndrome, because this WPW syndrome is associated with increased risk of arrhythmias. Increased risk of arrhythmias. Why? Because ventricle gets pre-excited early, right? But electricity has a basic tendency. Wherever there is a potential difference, electricity will flow in that direction, right? I can't say that I'm sitting in a hot tub and electrical cable falls in one end of the tub and it will not reach me. It will reach me because there is potential difference, right? If it has fallen on that side, why the electricity should come here? It will come because wherever there is potential difference, electricity will flow. So now the electrical impulse which has reached the ventricle, another impulse has reached the AV node, right? And this accessory pathway may be a fast conducting pathway, so it may take it much faster to the ventricle even before the depolarization wave has reached the AV node. So now AV node is at lower potential compared to this ventricular site which has got depolarized. So electricity can flow back towards the AV node, right? And this can become one of the reasons for developing the arrhythmias originating in the atria. So WPW syndrome increases the risk of developing arrhythmias from the atria, which we call as supraventricular arrhythmias like SVT or the atrial fibrillation. So for that reason, WPW syndrome is important for us, right? So before moving forward with the conditions where the PR interval is prolonged, we will try to identify how to recognize WPW syndrome on a ECG. Okay, so now let us talk about WPW syndrome. WPW syndrome is where patients are born with a extra conducting pathway. WPW syndrome is where patients are born with a accessory pathway which is bypassing the AV node and directly delivering the wave of electrical impulse to ventricles. So this accessory pathway is called as bundle of Kent. Bundle of Kent. So in these patients, this is my right atrium, left atrium. Somewhere between the atria and ventricles, there is a extra pathway. So this is SA node, this is AV node, and let me say that there is a breach here. So this breach is what I'm going to call it as the accessory pathway, and it is a fast conducting pathway through which impulse will reach the ventricle before AV node sends it, right? So this pathway is what we are going to call it as the bundle of Kent. Now, in these patients, will I get any abnormalities of the P wave directly if there is no arrhythmia? No. Who is the pacemaker of P waves? For the atria, it is still SA node. So, SA node will cause the depolarization of the atria, and I will get a P wave. I will get a normal P wave. But after P waves, I am supposed to get a PR segment, right? Normal duration PR segment in normal case, and this PR segment is due to AV nodal delay. But now what is happening? I'm bypassing this, and ventricle starts getting depolarized early. So QRS complexes will start appearing early. So a normal ECG should have been somewhat like this, but now what happens? The ventricle start getting depolarized early. So my Q wave starts appearing early. Now there is another important point to learn here. Do you think the entire ventricle will get depolarized from the electrical impulse traveling through the atria, or only the small area gets depolarized early? Small area gets depolarized early, or entire ventricle? It's only the small area. Why entire ventricle cannot get depolarized from this accessory pathway? The amount of voltage required to cause the depolarization of the entire ventricle is very high. That much I can only pass down through the AV node. So I can pass down only a little bit, only small area of the ventricle get depolarized, which starts showing up the signs of depolarization early, right? But rest of the ventricle gets depolarized from the impulse coming from the normal pathway. So this depolarization wave will not sustain, or it will not cause the repolarization of the rest of the ventricle. So this depolarization wave will go and connect the rest of the ventricle's path. Rest of the ventricle is getting depolarized from the normal pathway. So now what I'm getting? I am getting a wave which is going and connecting the normal pathway, and then rest of the ventricle got depolarized, it got repolarized, so rest of the things look fine. So now what happened here? This is my P wave, and what happened to the PR segment now? PR segment become shortened, right? Normal PR segment should have been from here till here, but because some part of ventricle started getting depolarized early, PR segment became shortened. So first thing I notice in the ECG of WPW syndrome is short PR interval. Short PR interval less than 3 small squares. Many times you can only identify P waves. Right next to P wave is the QRS complex itself, because absolutely almost simultaneous depolarization of the ventricles right after the atria ventricle starts, no delay at all, right? And because of this, what happens to the QRS complex now? Is it of the same duration as before, or it has become wide? Started early, later catching up with the rest of the wave, but now my QRS has become wider, right? So the second change I notice in the WPW syndrome is wide QRS. Why QRS started becoming wider? Not because it is taking more time for the left ventricle to get depolarized, but rather because some part got depolarized early. So depolarization wave started early. Rest of the wave took the same time, but overall now the width has increased. So I will get wide QRS. Remember, normal QRS is 80 to 120 milliseconds max. On an average, it is 80 to 100. It will be now more than 120 milliseconds. So when it is more than 120 milliseconds, we call it as wide QRS. Third change. Now this R wave is not taking off vertically like it would generally do if I launch a rocket, right? If I launch a rocket, it just goes up, right? ISRO launches fantastic. So it has a vertical, almost vertical, right? Only slight slant, normal R wave. But this R wave has an initial significant slant, and then it is picking up like the normal R wave. So this slant that we get initially, this slant is what we call as the delta wave, right? We will call it as delta wave. So what changes I'm noticing here? The PR interval is become short. PR interval is very short, and as a result, the QRS has become wide, and this QRS has a delta wave. Some ECGs of WPW syndrome may show T wave inversion, some may show normal T wave. So T wave inversion is not absolutely necessary for the diagnosis. But these three findings, short PR interval, slanted R wave upstroke, which we call it as, also called as delta wave, and wide QRS complexes, right? With or without inverted T waves, is the ECG findings that we are getting in a patient with WPW syndrome. And what we have learned so far, by having this accessory pathway, we run the risk of developing supraventricular arrhythmias like the PSVT and atrial fibrillation. So WPW syndrome is associated with increased risk of paroxysmal supraventricular tachycardia and atrial fibrillation. Atrial fibrillation. Now let us see if we can recognize the WPW syndrome on a ECG. Just give me a second. Now look at this ECG and let us go through the changes. So first thing I want you to comment down is on the PR interval. So when I look at this ECG, right, what appears to be the PR interval? I have P wave. This is the P wave, right? Can you see the highlight that I'm doing? This is the P wave. And what is the PR segment? Absolutely non-existent, right? The moment P wave finishes, the QRS complex is taking off. QRS complex begins soon after the P wave. So here, the PR interval is equal to P wave. There is no PR segment at all. So the PR interval is significantly shortened, right? What could be the PR interval here? It appears to have two small squares. Two small squares. That means 80 millisecond. Normal is 120 to 200. So that means PR interval is short. Second thing I notice is that R wave upstroke, right? It's like not going vertically like this in a normal ECG. It has a slant. This slant is what we call as the delta wave, right? This slant is delta wave. And because of the early beginning of the QRS complex, now the QRS complex stretches this wide, right? It is definitely more than 3 small squares, appears to be almost 5 small squares. That means the QRS has become wide. And I told you, not all ECGs of WPW may have inverted T wave. In this ECG, I don't see the inverted T wave. So this is a classical ECG picture of WPW syndrome. So this is the finding that we are expecting. P wave, short PR interval, early some area of the ventricle getting depolarized early, then catching up with the rest of the wave. So this giving a small slant called as delta wave, and the widening of the QRS because of the early beginning of the depolarization. So that is wide QRS. These findings help me to diagnose WPW syndrome. Okay. Now, short PR interval for the exam, most important thing is we should be able to recognize the WPW syndrome on the ECG, right? Otherwise, drugs, I will do one more session. Tachycardia and short PR interval is never a question in the exams. Now, after short, what is important from the exams perspective? It is the prolonged PR interval. Prolonged PR interval. So, in what conditions I can have prolonged PR interval? When do I call it as prolonged? PR interval more than 200 milliseconds, or in terms of small squares, more than 5 small squares on the ECG is suggestive of prolonged PR interval. What does this indicate? PR interval is about time for atrial depolarization plus AV nodal delay, right? So I can give a simple mathematical equation. It is the time for atrial depolarization plus AV nodal delay. So atrial depolarization is P wave, AV nodal delay is PR segment. Together is the PR interval. So time for atrial depolarization doesn't change significantly in most conditions, but AV nodal delay does vary significantly in physiological states as well as pathological conditions. So I can say that I do use PR interval as an indirect marker of AV nodal delay, whether there is AV nodal delay present or not. If it is absent, PR interval is short, like in WPW syndrome. And if AV nodal delay is increased, like an impulse come to AV node, it holds on to more than usual time and then passes it on to the ventricle, then the PR interval will become prolonged, right? So PR interval can be prolonged in what causes I can talk about. When AV nodal delay increases because of drugs or because of other conditions, we call that condition as AV nodal blocks. So typical prolonged PR interval can be expected in AV blocks, drugs, and other conditions where I am expecting bradycardia. Bradycardia can also increase the PR interval. But remember, when PR interval exceeds the normal threshold, see, let us say that my heart rate as of now is 100, and at 100 my PR interval may be 140 milliseconds. If my heart rate slows down, it may become 150 milliseconds, 160 milliseconds. So it is increasing the PR interval. But when it crosses 200 milliseconds, I will no longer call this as just simple bradycardia. I will again call it as AV blocks only. So AV blocks are our single most important causes for prolonged PR interval. So today we are going to learn about different types of AV blocks, right? So what we will try to understand is how our communication between the atria and ventricle is happening. It is happening through AV nodes, right? So SA node sends a signal and AV node passes it down to his bundle branches and Purkinje fibers. There is no other excess. Now every time SA node sends a signal, AV node is bound to transfer the signal to ventricles, right? Only thing is it is supposed to do its due delay. Whatever is the due delay, more than jada, no extra time it should take, no less time it should take. It should take appropriate amount of time and then transfer it to the ventricle. So in a normal ECG, if I have one P wave, how many QRS complexes should be there? If I have one P wave, there should be one QRS complex, right? So normal ECG always goes like this: P wave, QRS T, the next P, QRS T, because P wave is due to atrial depolarization, followed by ventricular depolarization is giving me the QRS, right? Now, if AV node receives an impulse from the SA node, atria is depolarized, I get a P wave. This AV node takes more than usual time but transfers it. It receives, delays more than required and transfers it. So what ECG finding I will get? The PR segment will become prolonged. So PR interval will become prolonged, but I will definitely have a QRS after that. Why? Because ventricle is also getting depolarized. AV node is passing the impulse down. So 1P will be followed by prolonged PR segment and then I will have normal QRS complexes when only delay is there. Conduction delay by AV node. But what if SA node sends an impulse, causes atrial depolarization and it reaches the AV node, but AV node fails to pass it down to the ventricle. If it fails to pass it down to the ventricle, will I have the QRS on the complex? Will I have the P wave? Yes, because atria got depolarized, right? But will I have the QRS? No. Why no QRS? Because ventricle is not depolarized, because AV node has not passed down the electrical impulse, right? So what do we learn? AV node abnormality can be either slowing down more than required, increased delay, or failure to transfer at all, no transfer at all happening. Both we will call it as AV blocks. And how do I recognize whether conduction delay is happening? When PR interval becomes prolonged. How do I recognize where the conduction failure has happened? When the QRS becomes absent, right? So based on this understanding, we will classify the AV blocks, AV nodal blocks into three major types. The first one, we will call it as the first degree AV blocks. We will call it as first degree AV block. What is the pathology here? The first degree AV block is where only the AV nodal delay is increased, but every impulse coming from SA node, it is passing down to ventricle. So will I have a missed QRS in this case? Of course no, right? Why I will not have missed QRS? Because Every time SA node sends, AV node picks it up, does a little more than unwanted delay, and then passes down to ventricle. So 1P will be followed by 1 QRS, but in between increased PR interval. Right? So first degree AV block is where we will talk about two abnormalities: conduction delay and conduction failure. So in first degree AV block, there is only conduction delay. Conduction delay is present, there is no conduction failure. That means I will only get prolonged PR interval, right? So in terms of ECG here, we will have only prolonged PR interval. Will I have a missed QRS? No, because conduction failure is not there. Ventricle gets depolarized every time. So there will be no missed QRS. No missed QRS. Then we have a second degree AV block. Now what happens in second degree AV block? Here there is conduction failure also. Conduction delay may be there, may not be there, it doesn't matter, but definitely there is conduction failure. So when there is conduction failure, I will encounter missed QRS. So if I have missed QRS, the rule number one is that I don't have first degree AV block. If missed QRS is there, it is higher than first degree. Maybe second degree, maybe third degree, but not definitely first degree. First degree, there is no conduction failure, so no missed QRS, right? So in second degree AV block, there is conduction failure. So we will have missed QRS. Conduction delay may be there or may not be there. Conduction delay plus or minus, but conduction failure is there, that too intermittently. Conduction failure is present, failure is present, and that too intermittently. That means all the QRS complex are not going to become absent, only few. Whenever the AV node fails to conduct the impulse, the QRS goes missing, right? So let us say that first impulse came, AV node picked it up and transferred. So I will have P and then I will have QRS. Next impulse came, it picked it up and then transferred. So I will have QRS. But the third impulse came, I had a P because atria got depolarized, but AV node failed. So then this time I will not have a QRS complex appearing. So intermittent missed QRS. Now this second degree AV block, we are further dividing into second degree AV block MOBIDS type 1 and MOBIDS type 2. MOBIDS type 1. MOBIDS type 1, we have also called it as Wenckebach's phenomenon. It's also called as Wenckebach's phenomenon. So what happens here? So in these patients, the conduction delay is there. So conduction delay, I said, can be there or need not be there. In these patients, conduction delay is there, and the conduction delay progressively goes on increasing. So first time, the AV node holds it for, let us say, a fraction of second extra. Like let us say 20 milliseconds, it took extra. Second time, it holds it more. It holds for 40 milliseconds extra. Third time, it holds it more for 60 milliseconds extra. Fourth time, it may not be able to pass down the signal. So first time P will be followed by QRS, but the prolongation in the PR interval will be visible. Second time, P will be followed by QRS, but the prolongation is even more than before. Third time, the prolongation is there even more than before. But fourth time, I have a P, but now there is conduction failure. So then I will not get the QRS at all. So fourth QRS will go missing. It need not always be fourth. It may be third, fifth, sixth, but intermittently there is missed QRS. And before that, there is a story of prolongation of the PR intervals. So here we will get serial prolongation of PR interval. Serial PR interval prolongation till I encounter a missed QRS. Serial PR prolongation till a missed QRS is encountered. Means serially delay is increasing. Some point it fails to pass on the impulse to the ventricle. So then I will have a missed QRS. After that, the whole cycle repeats again, right? Every sixth, seventh, or whatever number the QRS is going missing. After that, the whole cycle will repeat again. Next sixth or seventh QRS will go missing. This is my MOBIDS type 1 or first degree MOBIDS type 1 second degree AV block. Okay, now we also have a MOBIDS type 2 second degree AV block. MOBIDS type to second degree AV block. Okay, I don't have any additional name for it. I'm not going to call it as Wenckebach's anymore. Here what happens? The PR interval is not serially prolonging. Why? Because AV nodal delay is not going on increasing. AV node is functioning fine, right? Every time SA node sends a signal, there will be a P wave. AV node does the delay. It may be normal delay or more than usual delay, and then it passes on to the ventricle. Next time, same amount of delay that was there in the previous beat, and then it passes on to the ventricle. Third time, same amount of delay that was there in the previous, and then it passes on to the ventricle. That delay may be more or normal. But out of nowhere, suddenly, fourth time, it may not be able to conduct the impulse to ventricle. It fails. So now the fourth QRS will go missing. But now when I look back, my PR interval is constant only. That may be normal PR interval or prolonged PR interval, but it is constant only. With a constant PR interval, intermittent missed QRS. That is Mobitz type 2. Serially prolonging PR interval with intermittently missed QRS. That is Mobitz type 1. So in Mobitz type 2, we will have constant PR interval with intermittently missed QRS. Intermittently missed QRS. That is Mobitz type 2. Now based on after how many P waves we have a missed QRS, we can come out with a ratio. What is the ratio between the P waves and QRS? And based on that, we can also express it as a ratio, like 2:1 block or 3:1 block, right? We can express it in terms of ratio. Not important, as long as you're able to recognize which one is Mobitz type 1 and which one is Mobitz type 2, right? Now I will take you through some ECGs and let us see if you can recognize which type of AV block it is. Just give me a second to pull out the ECGs. So here I have a set of ECGs and some of them are having the AV blocks. So let us see if we can recognize them. So let's go through each ECG and we will look at the PR interval and whether there are any missed QRS. So in the first ECG, right? The first ECG, this ECG. What do I notice? First, I will try to see if there is any missed QRS. Okay. I find a P wave. After that, I have a QRS. Then I have a T. Then again, I have a P, QRS, T, P, QRS, T. So if I say 1P is always followed by 1 QRS, that means in this ECG, there are no missed QRS, right? 1P, 2P, 3P, 1 QRS, 2 QRS, 3 QRS. The ratio is 1:1. There is no absent QRS. That means there is no conduction failure. So can this be second degree AV block? Absolutely not. Second degree or higher will always have missed QRS. So that is ruled out. Only possibility is this can be first degree. First degree, how do I recognize? First degree is defined as just prolonged PR, no missed QR. There is no missed QRS because there is no conduction failure, only conduction delay. So when I look at it, it's very clear. The PR segment itself is taking 5 small square, right? So that means it is PR interval is definitely more than 200 milliseconds, right? So here it is 5 small squares plus another 4 small squares. So it is 9 small square. So if it is 9 small squares, what is the PR interval here? 1 small square is 40 milliseconds into 9. So that means I am dealing with 360 milliseconds. And what is the normal PR interval? 120 to 200. Definitely way more than that. So that means here PR interval is prolonged but no missed QRS. So I have a clear case of first degree AV block. Now in the second ECG, when I see the second ECG, what do I notice? The first thing that I notice is that there is probably a missed QRS, right? Just to reascertain, I will see how many P's I am getting and how many QRS I am getting, right? This is a P, this is a P, this is a P, this is a P, this is a P. Each P normally, if there is no conduction failure, should be followed by a QRS. This P is followed by a QRS, yes. This P is followed by a QRS, yes. This P is followed by a QRS, yes. This P followed by a QRS, no, right? I am expecting a QRS to be here, but I don't see. What do I get? I get another P wave right next to it. Means the QRS that was supposed to appear here is missed. So when I have a missed QRS, I know that it is a second degree AV block or higher. It is not first degree. Now second degree is of two types. What are those? First one is Wenckebach's phenomenon or Mobitz type 1. Second one is Mobitz type 2. Now how will I differentiate between the two? I have to see the PR interval, whether it is constant or before the mist it was serially prolonging. So now when I look at this ECG, let me try to calculate the PR interval from the beginning, right? This is the first wave. Let me use blue color to demark. First complex, that is the PR interval. Second complex, this is the PR interval. Third complex, this is the PR interval. So how many small squares the first complex is taking? It appears to be around 5 or maybe little more, right? Let us consider it as 6 itself. So if I consider it as 6, then 6 into 2, 6 into 40, this becomes 240 milliseconds. So in the first complex, the PR interval is 240 milliseconds. The next one, here it appears to be like 5 here, little more on this side and little more than 1 on this side. So roughly 7 small squares. So 7 into 40 is 280 milliseconds. Now when I go to the next ECG complex, here it is almost like 8, right? 8 or more than 8. 5 plus 2 plus 2. So almost 9 small squares. So then it has become 9 into 40, 360 milliseconds. So can I say the PR interval it went on serially increasing before I encountered a missed QRS. So that is a classical story of Wenckebach's phenomenon or Mobitz type 1. Okay. Now when I look at the next ECG again, in the next ECG, the examiners asked me to identify whether there is AV block. So I have the mental conditioning that I am looking for AV block. So first thing I will see is whether there is any missed QRS. How do I recognize? I will first label all P waves and then I will see whether each P is followed by QRS. So first P is followed by QRS, yes. Second, yes. Third, yes. Fourth, no. There should have been a QRS, but it is missed. I am directly encountering the next P. So here I have a missed QRS. Now if there is a missed QRS, it can be second degree or higher. And in second degree, I have two types, Mobitz type 1 and Mobitz type 2. Now I have to decide which type it is. For that, I have to look at the PR interval. So now when I look at the PR interval here, even one gross look, right, it appears to be constant, right? It is not varying. In the above ECG, it was increasing from beat to beat, serially prolonging, right? Here it is constant. It appears to be around 4 small squares or 5 small square. It appears to be constant, but despite having constant PR, suddenly one QRS goes missing. That's typical story of second degree Mobitz type 2 AV block. Now this Mobitz type 2 itself, based on what is the ratio of P and QRS, I can express it as 3:1 or 2:1. Like you see in this ECG, this can be called a second degree AV block, which is nothing but Mobitz type 2, right? But we are able to express it in terms of ratio. So just look at this. Here, how many P waves I am getting? One P, one QRS, right? Another P, QRS is missed. One P, one QRS, right? Another P, a QRS is missed. Then another P and a QRS. So here I can see that for two P waves, I have one QRS, right? So the ratio between the number of P's and Q is 2:1. So I can also have 3 P waves for 1 QRS. So in that case, we will call it as 3:1 AV block. Most cases, we will not be able to assign such ratio. Like in this case, right? In this case, how many P waves are? 1, 2, 3, 4, 5. When I calculated 5 P waves, how many QRS I am getting? 4. So can I call it as 5:4 blocks? Doesn't make much sense, right? So we'll simply call it as Mobitz type 2. But if the missed QRSs are so frequent that where I can assign a 2:1 or a 3:1 ratio, I can do that. This is the story of Mobitz type 2 second degree AV block, right? So now, so far we have learned how to recognize first degree and second degree AV blocks. First degree, only conduction delay, so prolonged PR interval is the only observation, no missed QRS. Second degree, there is always a conduction failure. So we will have intermittently missed QRS. Conduction failure is intermittent, not constant. So whenever it fails, I'll have a missed QRS. Now that missed QRS may appear with a preceding constant PR interval, then it is Mobitz type 2, or it may appear after serially prolonging PR interval, then it is Mobitz type 1. Okay. Now we will understand the third degree AV blocks. Third degree AV blocks, which is also called as complete heart block. It's also called as complete heart block. So what happens in complete heart block? In complete heart block, there is absolute conduction failure. Means AV node is not able to pass down even a single wave of electrical impulse to ventricle. SA node, it may be sending whatever it wants. AV node is not able to transfer it down. Then we call it as third degree AV block or complete heart block. So in third degree AV block, there is no question of conduction delay at all, because if I transfer only, then the question of delay comes, whether I took it more time or whether I took less time. There is absolute conduction failure. Absolute conduction failure. AV node is not able to conduct at all. So then in the ECG, what do I get? Should I get P waves or no? Should I get the Umar, I will address your queries. I will address. Should I get the QRS or no? Okay, remember now. This is my heart, right? And we know that I can only pass the electrical impulse down from the atria to the ventricles through the AV node, right? Okay. Now just think about it, that if the AV node is completely blocked, AV node is completely blocked, so will there be any transfer of impulse? No. Then will the person die? So very first lesson on the ECG, we have learned that every structure in the hierarchy except the atrial myocardium and ventricular myocardium are capable of becoming their own pacemaker. So as long as SA node is a pacemaker and it is sending an impulse, AV node is taking it and passing it down. But if AV node becomes completely blocked, if it is not able to pass down any impulse from above, the remaining structures can become pacemaker of their own. So his bundle or bundle branches or Purkinje fibers will become pacemaker, and they will cause the depolarization of the ventricle. So when I have a complete block, what is the situation? Now I have a pacemaker for the atrium and a pacemaker for the ventricle. So for atria, my SA node is becoming the pacemaker, but for ventricle, something below the AV node, his bundle or bundle branches or Purkinje fibers, they are becoming the pacemaker. Is it good to have two pacemakers in the heart? It is like a family. Heart is like a family which is run beautifully by a leader, right? Her family ka ek leader hota hai, right? All your medical colleges need a leader, the dean or the principal. Her department also needs a leader, HOD, who gives the direction. That leader is SA node. SA node is running the show. But if in the medical college, right, one of the HOD becomes rogue, the college cannot run properly, right? In the family, one of the family member becomes rogue. He is not able to listen to the head of the family structure becomes destroyed, right? Same can happen with heart. So if I have two pacemakers, let us say SA node is a pacemaker and his bundle has become a pacemaker. Why this is going to be problematic to the heart? Because the rate of automaticity of these structures are different. The rate at which SA node can start an impulse is 60 to 100, right? That is its rate of automaticity. But what about the rate of his bundle? His bundle is 25 to 40, right? His bundle is 25 to 40. So now my atria will be contracting at a rate of 60 to 100. My ventricle will be contracting at a rate of 25 to 40. Why is this not good for the heart? Remember, if this is my atria and I have a ventricle here, when atria contracts once, ventricle receives once, then ventricle ejects it. Next, again, atria contracts once, ventricle receives it and it ejects it. So there is a beautiful asynchrony. Atria first gives to ventricle, then ventricle ejects. Now, if atria contracts 50 times, but ventricle is able to contract only 30 times. So many times, the outcome of this is that atrial rate is higher, ventricular rate is less. So many times it may happen that atria and ventricle contract simultaneously. And if that happens, will I be able to transfer the blood to ventricle? Both are contracting simultaneously. So ventricle does not receive blood. Now this ventricle contracted without receiving the blood. So now will there be any ejection during this contraction from the ventricle? No, because I did not fill anything into it. So that is an empty ejection. So ejections are becoming ineffective. So first of all, ventricular rate is decreased. Ventricle is only ejecting at 25 to 40 times per minute. And we all know that cardiac output is equal to stroke volume into heart rate. And within that, many of the times contractions were empty, no stroke volume only. So the net cardiac output, one side heart rate is decreasing, on the other side many contractions are relatively empty with zero or very minimal stroke volume. So cardiac output is going to become severely low. So low cardiac output will start affecting the functions of various organs. That's why third degree heart block or complete heart block is dangerous for the survival. Right. Now on the ECG, how is it going to look like? Right. We'll see how is it going to look like on the ECG. How can I identify it? We'll understand the concept. For the atria, who is the pacemaker? SA node. What is the atrial rate in that case? 60 to 100. Right. So let us say this is, I'm only recording the ECG for atria and its rate is going to be 60 to 100. So this is how the ECG is going to look like. Each P wave is representing one atrial depolarization. But ventricular rate, let me say it is 25, right? So in that case, the QRS will appear less frequently, right? The QRS will appear less frequently. Its rate is not as much as that of the ventricular rate. So QRS will appear less frequently. So now the resultant ECG is going to be the superimposition of these two, right? So if I superimpose this ECG on the above ECG, what do I find? When I look at the relationship between P and QRS. In any other condition, what do we noticed? We had a P which was followed by QRS. Atria contracted and filled the ventricle, and then ventricle contracted to eject. A P was followed by QRS. Only intermittently some QRSs were getting missed in the Mobis type 1 and Mobis type 2. In first degree, no missed QRS. But now what do I notice here? This relationship between P and QRS is destroyed, right? P, sometimes it is coming before the QRS, sometimes it is coming after the QRS, again it is coming before, sometimes it is buried inside the QRS, sometimes after the QRS, sometime before the QRS. So there is no connection between P followed by QRS. Normal thing is P followed by QRS, P followed by QRS. It is destroyed here. This condition we call it as AV dissociation. Atria and ventricle are separated. Atria is contracting on its own at its own rate because its pacemaker is SA node, and ventricle is now independent. Its pacemaker is His bundle or bundle branches or Purkinje fibers. So it is contracting on its own rate. So when they are contracting at different rate, atria much faster, ventricle relatively slower. So sometimes they are contracting simultaneously, like here. This time ventricular filling will not happen because both of them are contracting simultaneously. Sometimes atria is contracting before the ventricle. That time, like here we saw, ventricular filling can happen and the filled ventricle may eject good amount of blood. Sometimes ventricle finishes the ejection, after that atria contracts. So now we have lost it completely, right? Atria and ventricle are behaving on their own, and the net result is only few contractions of the ventricles are effective. First of all, rate is less and only few are effectively ejecting the blood. Remaining contractions, the one that happened during the atrial contraction, the one that happened right before the atrial filling, atrial contraction, all of them are ineffective contractions. So the net result is cardiac output is going to be severely down. So we are going to call this condition as AV dissociation. So when atria and ventricle become separated in terms of functional attachment, two conditions: either atrial rate becomes more than ventricular, like we are seeing in AV blocks, or ventricular rate becomes more than atrial. When ventricular rate becomes more than atrial, when we have conditions like ventricular tachycardia or ventricular fibrillation, where atria is contracting at normal rate but ventricle is contracting at much higher rate. So the ECG there will have more QRSs and few P waves. Again, the end result is lot of ineffective contractions. So that's why, because of severe reduction in the cardiac output, third degree AV block is the most dangerous AV block. It's okay to have a first degree AV block. It's okay to have the second degree Mobitz type 1, but the third degree AV block is not acceptable at any cost. I don't want to have two leaders in my cardiac chambers, right? It should always have one leader to maintain the relationship to flow nicely in the family. If it becomes two leaders, it's always conflict, just like India, Pakistan, right? So I don't want a second pacemaker to emerge. And the risk of second pacemaker emerging is high in patients with Mobitz type 2 block, because your his bundle is waiting for the AV node to send an impulse. If AV node does not send an impulse at any point of time, his bundle may decide like, okay, now I am the leader and now I will run the show for the ventricle. So Mobitz type 2 usually tends to progress to third degree AV block. So what are the dangerous AV blocks? Mobitz type 2, because it can become third degree, so definitely it is dangerous, right? So now I know how to recognize them. Let us see if we can recognize it on the ECG as well. So just give me a second to pull out the ECG. So if we are able to recognize third degree, then we are quite done with respect to PR intervals. So now let us look at this ECG. When I look at this ECG, right, a quick outlook may not make me suspect the possibility of AV blocks, but I should still. Why? I have to see the relationship between the P and QRS. So here I see a P wave. Okay, it is followed by QRS with a very wide PR interval, right? Look at the PR interval here. 1, 2, 3 large boxes plus almost 4 large boxes, right? Each large box is 200 milliseconds. So 200 into 4, literally 800 milliseconds is a PR interval. Okay, let me ignore that. A P is followed by QRS. After that, I see some deflection and then see one more deflection. After QRS, one of them can be T wave. This or this can be T wave, but whatever else is wave, what it can be, I have to consider it as P wave, right? So I'm going to consider this as the P wave because it is morphologically similar to other wave which I've considered as P wave. So then this is most likely T. So now what do I notice? A P is followed by QRS, but P is again appearing right after QRS. Normally what happens? A P is followed by QRS, a P is followed by QRS, except missed QRSs, right? Next, again I see a P wave, then a prolonged PR, and then a QRS, then I see a T. After T I see something, another wave which is morphologically similar to P. So again I have to label it as P. So one time P is coming before QRS, one time it is almost buried into the QRS, one time it is coming before QRS, next time it is coming after T, next time it is coming before QRS. So sometimes before, sometimes with or buried into QRS, sometimes after T. So there is no relationship between P and QRS. इनका dissociation or divorce हो गया है. So that means this is third degree AV block. So that means this patient has two pacemakers. This P is the SA node for the atria, and the QRS something below the AV node, that is his bundle or the Purkinje fibers have become the pacemaker. So if I calculate ventricular rate, it is way less compared to the atrial rate. This is what we call as the AV dissociation, and in this case it is third degree AV block. So now that I know how to recognize all these AV blocks, the last question I have to address before we wind up for today is, how do I manage them? How do I manage AV blocks? Okay, so in terms of management, the first degree AV block is considered as benign. I don't need to do much. So for first degree AV block, it does not progress. It does not tend to cause any missed QRSs. So my cardiac output is not going to get affected largely. Only thing is that AV node is taking little more time to transfer the impulse to ventricle. During that period, ventricle is getting filled. No impairment in ventricular filling, no impairment in its ejection. So first degree AV block needs nothing. It is benign entity, and treatment wise we are only focusing on reassurance. Reassurance. If you recognize that some drug like beta blockers or the calcium channel blockers are responsible for it, you can withdraw the drug. Otherwise, nothing needs to be done. But this is a very dramatic scenario. I've seen a lot of relatives, friends rushing to me saying that I got an ECG done and it is showing some block. For them, block is equal to coronary artery block. So they think that it is MI. But this is first degree AV block, which is benign. It's not likely to cause any major trouble to the patient. Reassure and leave it. The second one is the second degree Mobitz type 1. Mobitz type 1 is unlikely to progress to the third degree AV block. The risk of progression is less. But whenever I had a missed QRS, that time ventricle did not contract and eject blood. So cardiac output may be low. Now, depending on how frequently missed QRS are happening, the cardiac output will be proportionately low. If every third or fourth beat is being missed, then the cardiac output will be significantly low, because cardiac output is stroke volume into heart rate. So if heart rate is 60, and out of that, like atrial rate is 60, but out of that 10 is not passed on to ventricle, so effective heart rate is only 50, so the cardiac output will be less, right? So in such cases, if there are symptoms of low cardiac output, I need to treat. If there are no symptoms of low cardiac output, these patients need not be treated. If there is an underlying cause like drugs, withdraw it. But otherwise, in terms of active treatment, nothing needs to be done. So Mobitz type 1 is treated only if Mobitz type 1 is treated only if there is symptoms of low cardiac output. Now, what symptoms of low cardiac output I can expect? If cardiac output is low, I may not be giving sufficient blood to brain, so I can expect syncopes or episodes of loss of consciousness. Also, my systolic BP is directly proportionate to cardiac output. So if the cardiac output is low, my systolic BP can become low. So I can have hypotension. So if I have hypotension, syncope or episodes of loss of consciousness, or if I'm not able to tolerate the effort, I can't climb one floor because before that I feel fainty because my heart is not able to increase the cardiac output to give to my brain. In that case, I need to be treated. Otherwise, there is no need to treat. So symptoms of low cardiac output will include: 1, hypotension; second, episodes of loss of consciousness or syncope, right? Then third, effort intolerance, not able to tolerate effort. In such cases, we need to treat these patients. If these symptoms are not there, Mobitz type 1 also do nothing, just closely monitor, follow up regularly. But if it is Mobitz type 2, the second degree Mobitz type 2, it is not a benign entity. If it is second degree Mobitz type 2, there is always a risk of progression to complete heart block. And complete heart block means two separate pacemakers in the heart. And when I have two separate pacemakers in the heart, atria and ventricle are getting divorced. So family is going to collapse. I don't want it. So that's why Mobitz type 2 is always treated, right? So Mobitz type 2 carries high risk of progression to complete heart block, progression to third degree AV block or complete heart block. And for that reason, these patients are always to be treated, always to be treated. Okay, that's clear. Now coming to third degree AV block or complete heart block, these patients have their family collapsing. Ventricle is behaving in its own way at lower rate, atria is behaving its own way at higher rate. So family is disintegrating. So these patients will invariably develop the symptoms of low cardiac output and they invariably need to be treated, right? So they also need to be treated, right? On priority, treat on priority. This is like a kind of medical emergency. We have to treat them. Third degree AV block is always treated. Mobitz type 2 is also always to be treated. Mobitz type 1 only if symptomatic, and first degree nothing needs to be done. So the last question is treat, treat, treat. I am repeatedly telling you we should treat these patients, we should not treat these patients, but how do I treat? We decided when to treat, but how do I treat, right? So for treatment, what is going to be my first line management? What is going to be my second line management? And what can be considered as a definitive treatment? So first line management, see why I should treat heart blocks? Because complete heart block, two separate pacemakers, ventricular rate is very low, atrial rate is very high, they are contracting randomly, sometimes ventricle gets filled, sometimes no, it does empty ejection, so cardiac output will be very, very low. And this low cardiac output is going to affect my brain, affect my kidneys, affect my livers, affect my overall survival chances. So my goal is to elevate the cardiac output so that I protect brain, I protect kidney, I protect liver and all other vital functions. So how can I elevate the cardiac output? What is the formula for cardiac output? Cardiac output is equal to stroke volume into heart rate. So somehow if I am able to increase the heart rate, my cardiac output can also increase. So that will be the goal of my treatment. Goal of my treatment. Now how can I achieve an increase in the heart rate? I can achieve the increase in the heart rate by attacking the autonomic nervous system. So I have a sympathetic and parasympathetic nervous system. Parasympathetic, what it does? It decreases the heart rate. Sympathetic increases the heart rate. So I can play with both, right? Either I can block the parasympathetic, which is supposed to decrease the heart rate. If it is blocked, heart rate will increase. Or I can stimulate the sympathetic. Sympathomimetics I can use to increase the heart rate. So our first choice is going to be using the parasympathetic route, right? Block the parasympathetic so that heart rate increases. And what drug we can use to block the parasympathetic? It is the IV atropine. So the drug of choice or the initial management of any AV block which requires treatment. When I say any, it may be Mobitz type 2 or third degree AV block. Their initial management is going to be IV atropine. Atropine will elevate the heart rate and thus somehow give you a better cardiac output. So your other organs are going to survive. But if atropine is not able to achieve the desired heart rate, which is 60 plus, in that case, as second line agent, now I can take the sympathetic route, right? I have already blocked parasympathetic. Now I can stimulate sympathetic. So what drugs I can use? I can use drugs like IV adrenaline, noradrenaline or dopamine. Noradrenaline or dopamine. But these are all not definitive treatment. These are all temporary treatments. Why? Okay, let us say I have got a patient who has got complete heart block because of calcium channel blocker overdosage. Calcium channel blockers like verapamil are known to cause AV block. So they have blocked the AV completely because he's taken 40 tablets of verapamil. Okay. Now I will start the patient on atropine. First I will give an IV bolus. Heart rate may shoot up a little. Then I will start him on atropine infusion. Right now, to overcome the side effects of atropine, because atropine is known to cause psychosis and other side effects, I might have to switch to adrenaline, noradrenaline or dopamine, or I'm adding both atropine as well as, let us say, adrenaline. Now how long I can maintain the patient on these? In case of verapamil toxicity, right, it may be fairly okay. Means these drugs may be able to give me the heart rate that I want, and for 1 or 2 days, 3 days, it's fine. They will be able to maintain. By that time the drug will come down, or I will take other routes to reduce the impact of drugs. I will use antidotes and all. So once the impact of the drugs comes down, AV node is back to normalcy. After that I don't need atropine, adrenaline or noradrenaline, right? But what if I have a condition where the underlying cause has no treatment? For example, let us say I have developed an MI, and as part of the MI, AV node is also dead, because AV node mainly receives the blood supply from the right coronary artery, and there was a critical block in the right coronary artery. Now AV node is dead, so AV node is getting blocked. It's not going to function. It's not going to come back because it is infarcted. So in that case, can I maintain the patient eternally on atropine, adrenaline, noradrenaline? No, because they need to be given IV. That's the first problem. Second is patients develop something called as tachyphylaxis, means on a long-term exposure, the efficacy of the drug will come down, either because of receptor down regulation or increased metabolism of the drugs. So tachyphylaxis is known to occur. So it's not going to be a long-term solution. So in such cases, what I can do? The only thing I can do is put the patient on pacemaker, right? So pacemaker is the definitive treatment. Whether I need that definitive treatment for all patients or not is a different story, where I have a clearly identifiable, like curable underlying cause and which can be handled in a very short span of time. I may not require pacemaker, right? When it is toxin induced or drug induced, I may be able to tide over the situation with the simple drugs itself. But when I have structural abnormalities of the heart, like ischemic heart disease, MI, or sarcoidosis, where there is a granuloma in the AV node, in such cases, it may not be reversible. In such cases, I have to directly go for the pacemaker. And even in cases where I have a reversible cause, if I'm not able to achieve the desired heart rate and thus the desired cardiac output, in such cases also I have to go for pacemaker. So that's why pacemaker becomes our definitive treatment. When I insert a pacemaker, whether it is going to be a temporary pacemaker or permanent also depends on the underlying cause. Like let us say I've got a verapamil toxicity case. I am not able to achieve the desired heart rate and thus the desired cardiac output with atropine and sympathomimetic drugs. So for this reason, I'm putting the patient on pacemaker because my drugs are not able to give me the result I want. Should I put a permanent pacemaker or temporary? Drug effect will wane off after few days. So till that time only I need a pacemaker. So in that case, I will put a temporary pacemaker. We will call it as TPI, temporary pacemaker insertion. But if I have an irreversible underlying cause, then I need a permanent pacemaker, right? So that's about our AV blocks and its management. So as usual, I will share few exercise questions on the ECG, which I want you to go through and solve them. Regarding the answers to previous questions, I do not have the previous PDF, so I will not be able to go through the numbers that you're mentioning, but I will get the previous PDF, solve, and the solutions, I will share it on the Telegram. So today you will get two PDFs, one the solutions for the previous questions, and then today's notes, and the solutions for today's problems we will address in the next PDF, right? So with that, I'm signing off, guys. I'll see you in the next class. Till then, have a good time. Regarding your doubts that some of you had asked, third year, okay. So if you're in third year, Umar, third year is the right now a golden period to start final year subjects because they have removed ENT and Optal and they have placed in final year. So third year, you only have forensic medicine and PSM. PSM do not ignore at all. It is going to be the gold mine for MCQs in the future. So study PSM well, forensic as much as you can do. You will have plenty of extra time. So utilize it for covering the final prof subjects. You can do two things. Either you can cover Optal and ENT in the third year because it's much more easier to integrate with the third year and keep medicine, surgery and all separate for final prof. So that once you reach final prof, your Optal and ENT is already done. Or you can do Optal, ENT and little bit of medicine surgery parallelly. So if you're doing medicine surgery parallelly, then focus on like in medicine, if you're following Harrison or if you're following Davidson, there will be a section on symptomatology, right? Try to complete that in third year. Rest of the medicine is going to become so easy if you have completed the symptomatology part, because in the symptomatology part, be it Harrison or be it Davidson, they discuss approach to each symptom. So once you have that clarity about approach to each symptom, right, medicine is going to be way more easier. Like for example, if I have a case of jaundice, I can study that this condition causes obstructive jaundice, that condition causes hepatocellular jaundice separately under the headings of those diseases inside medicine. But if I already have a clarity what is going to be my approach, all those diseases will start becoming easier. Like, okay, I already know that this will have obstructive jaundice and this is the diagnostic approach according to the symptomatology chapter. So rest of the medicine is more or less like revision of whatever you have studied in pathology, pharmacology, if you know the approach. And approach is like well combined in the symptomatology part of Harrison. So if you can finish that, more than enough to do in the third year. You can use Davidson because MCQs mostly come from Harrison. It's better that you do it from Harrison so that it is useful for your prof as well as MCQ. I'm not saying that remaining chapters you do from Harrison. That you can do from Davidson later when you go to final prof, or you can do it from video lectures or notes, whatever source you're following. But the symptomatology part, you do it from Harrison. Okay. So if there are no more doubts pending, I'll wind up for today. I'll see you again tomorrow in the next session. Right? And I don't know when it is scheduled, but I will definitely share the timeline as well. See you guys. See you. Bye.